We can get to. All right, so basically chest imaging lecture. This is just chest X-rays. It's gonna be a very brief intro and then basically just case-based, so that way everybody participates, and then y'all just think through, just I mostly want to focus on like a couple normal abnormal findings and how to describe them. So that way, if you ever have to relay what a chest X-ray looks like to somebody, you know what a differential is and how to verbally describe it, which can sometimes be kind of tough. So, all right, the basics. Anytime you read a chest X-ray, do it the same way. Whether you use the ABCD method or whatever method you use. And then two, chest X-rays are kind of like EKGs, where the quantity of how many you look at is just as important as the quality of your read. So anytime you admit somebody, I always recommend look at your chest X-ray and interpret it yourself. Only because if you see 100 that are normal, when you see one that's abnormal, it immediately will click in your mind like, that's not right. Party. Looking at you.
I know.
Just okay, so don't worry, you only missed one slide. Okay, so first things first, when you look at a chest X-ray, look at the quality. You have to have a good quality chest X-ray to actually see what you want to look at. I put these two pictures up here. So the one on the left, that's like super bright. This is going to be one that's technically underpenetrated, so you're not seeing through the tissue as well enough, and that's what has this bright appearance. And then the one on the right is going to be one that's overpenetrated. It's going to be dark. The lung fields are just super black here. You don't have a good cardiac silhouette. Now, clinically, what that means for us is how do I figure out how to make this the right contrast and the right, like essentially radiation amount? There is a nice little button. If you right click on your image, go to image processing and click this CLHAE. No idea what that stands for, but that will auto contrast to give you the best amount of radiation exposure and then contrast. So what you're looking for is black in the lung fields here, and then a technically appropriate X-ray is if you look at the vertebral bodies behind the cardiac silhouette, you can make those out. So whereas like, we go back, this one you can make out, but it's too dark. These you can't really make out and it's too bright. So that's the like standard, like what a chest X-ray should be penetrated. So that being said, clinically, all you need to know is right click, CLHAE, you'll get a easy picture. Okay. So next, the method, ABCDEs. The only reason I do ABCDEs, airway, bones, cardiac, diaphragm, and then basically everything else, is to basically use ABCDE to do everything else other than look at the lungs. Because when you look at it, the first thing you're gonna do is like, oh, what's in the lungs? And your eye's gonna be drawn to it. So this is just a way of going through to make sure you don't miss something. Do y'all use any other method? Or do y'all have any like?
ABCD.
All right. That's every lecture I've ever got on this is always the ABCDEs. So that being said, do y'all have any questions about those like very brief intro before we do cases? Okay. I figured I want to be quick with it since y'all all read chest X-rays all the time. So there's probably about 10 or 12 cases. Each one is a picture with a clinical vignette. Y'all just participate, or we can call on people, single you out. And just all I want you to do is just basically describe the chest X-ray, think about the wording you would use, and then give a differential or either the diagnosis to like say, this is what I think it is based off of that. So that way it'll stick with you. So that way you can see it again, just kind of builds that repetition memory. So let me do that. Okay. All right. 34-year-old woman, pleuritic chest pain, shortness of breath, unilateral leg swelling. Anybody want to take a stab?
So technical quality, I see what I need to see through cardiac silhouette with vertebral bodies. Airways midline with good tracheas. B, bones look okay, classicals, ribs. C, cardiac silhouette is not enlarged, doesn't have a big wide mediastinum. Diaphragms seem low in the chest, maybe a little hyperinflated, but with clear costophrenic angles. And then lung spaces look clear, no big infiltrates or big blown out things. So left lower extremity swelling, chest pain, shortness of breath, no acute pulmonary findings. I would think about like a vascular problem.
Boom. That was perfect. So this is, okay, there we go. Yep. This is a normal chest X-ray. You are totally correct. So the big takeaways, anytime you're worried about a PE, a chest X-ray is not going to show you anything of any value. And then don't ever be fooled by breast tissue. I've seen this called even by radiologists where it's a little bit denser here and here, like a lower lobe infiltrate, and it's just because the tissue is lying over it and it makes it look brighter. So don't ever be fooled by that, because if you look at the X-ray, you'll see it quite often. Okay. 77-year-old fever and a cough. You got it.
The quality is okay. You can see the people.
Yeah, I would say maybe like a low bar looking infiltrate, only because it can be tough to delineate. Is this a pleural effusion or is this consolidation? But I think this pretty sharp edge right here that runs along the lobe of the right lung is kind of the delineating factor. Like a pleural effusion would have a little bit different look than that would. So there's one other specific finding here that would also suggest this is consolidated lung and it is a pneumonia and not a pleural effusion. And it's these tiny little dark lines right here. Do y'all know what these are called? Hey, there you go. Yep. Air bronchograms. So basically all that means these are so this is the trachea coming down right main stem. And this is just the small airways that are seen with air in them inside of condensed consolidated lung tissue. So spot on. And then there's some little arrows. All right. Any questions on that one? All good. Okay. Oh, yuck. Okay. 55-year-old guy, lower extremity edema. So he's got lower extremity edema. He's short of breath. So he's on BiPAP. He's anemic. So he got 2 units of blood right before this. And he has a fever and he's septic and says he's coughing. So this one's a little more convoluted. Anyone?
So his airways midline for A. B for bones, you can see your vertebral body, your clavicle, maybe a little bit. Not that bad. A, B, C, cardiac silhouette, his heart doesn't meet the criteria for like enlarged, but it's on the bigger end, and his aortic notch is kind of prominent. C, D for diaphragm. My angles are a little blunted, I think, so I think he probably has bilateral pleural effusions, even though they're not huge. C for, or E for everything else. To me, I think he's volume overloaded. I have like little bat wings that you can see. And then I also wonder if he has like, I don't know, like either lung disease or like interstitial, just looking at like some of the little, I don't know the right word, it's just my word.
Well, this, no, that's spot on. So before differential, how would you describe like both of these lung fields? How would you relay that verbally for the picture? Does that make sense? Like you're calling,
medical.
Like you're calling me, I'm like, what did the chest X-ray show? And you want to describe that picture.
That's the thing,
It look-
not
so
very professional.
I would
Jacob.
take trash 100%.
Jacob, it looks like pulmonary edema, it's got the bat wings.
It's
It
got the
also
bat
looks
wings.
like some interstitial lung disease.
Okay, I like
as
interstitial.
well.
So I would, if you have something like this, I would probably call it patchy, diffuse interstitial infiltrates. So that way you have infiltrates in both lungs. It's a little bit patchy, maybe here, but it's very diffuse. I do agree with you. Looking at this guy with sternotomy wires and what looks to be like a mitral valve replacement, and then maybe a curly B line right here, probably is. But the one thing I want to think about is what are other things that could be other than pulmonary edema, given his little clinical scenario. Taco, that's one. Taco trolley, so a transfusion reaction. Anything else?
ARDS.
Boom, got it. What if I said he was coughing up a ton of blood?
Ooh, PAH.
There it is. Y'all got it. So pretty much the big takeaway is patchy, diffuse interstitial infiltrates is how I describe something like this. And then you can absolutely say like consistent with pulmonary edema. He's got the bat wings. That's probably what it is. But anytime you have this pattern, correlate clinically is the main key, because This chest X-ray doesn't tell me anything about what's going on other than what does the patient look like and what's their history tell me. All right, 22-year-old, young, lanky, skinny male, acute shortness of breath after he got tackled playing football. Bakers.
Pneumo.
Take a look at it. So his airway, maybe a little bit to the right side, but not too bad. Bones. Don't see anything that stands out abnormal there. Cardiac silhouette is fine, not too big. And part of everything, diaphragm. There's no effusions here.
Does that help at all?
And
Yeah, it
then
actually does, I think.
from a lung standpoint, looks like he has a pretty big pneumo on his left side.
I'm gonna leave the lights off just for this one so we can see.
Yeah,
But yeah, no, absolutely. It's just kind of hard to see, but you're spot on. Right lung. So the biggest thing, I think if you're ever considering clinically a pneumothorax, one, look at your picture and you can see there is a difference between this lung, like if you just look at it from 30,000 feet, this right here looks different than this here. And the biggest thing is you can trace these lung markings out and these kind of go all the way out here. Whereas these, you start to trace out and you like lose them and you're like, well, why is this, like, where's the rest of the lung tissue? Just because it's collapsed down. So absolutely, that is a large pneumothorax. Now for extra points, is this a tension pneumothorax? Yes or no? No. Why? Yes. All right, y'all got it. Y'all got it. Why am I even giving y'all this lecture? I don't already know this stuff. All right, so kind of like we talked about, trace the lung markings all the way out if you're concerned about a pneumothorax, mediastinal shift for tension. And then the last key point is invert the image. So if you right click, you can invert image where it's essentially black becomes white, white becomes black. That's just the lining of the lung. So in this picture on the left, it's very hard to see way up there. There's a very small apical pneumothorax, which is super easy to miss. But if you look at the picture on the right, kind of tracing this line up here is much more easy to see. So again, if you think about pneumothorax, look at the image, trace the markings, and invert the image.
that's a different case.
Yep, you know, this is a different one. So this is
I thought
like,
the same thing at first.
like that, yeah, no, this is like a rip roaring pneumothorax. This is a pneumothorax that you might see after somebody gets a thoracentesis or they had a chest tube and they have a little bit of apical pneumo left. So it's very, very easy to miss. I feel like we went through that quick. Questions at all? All good? Do you want me to leave the lights off? Is it easier to see this way or do you want me to turn them on? Okay. All right, we're like halfway through. We're good. Okay, 64-year-old female, lung cancer, just got some chemo. Now she comes in short of breath and onc is capped. And of course, hospital is accepting.
Airways, midline. Bones, I don't really see anything. It's a little bit. I guess underpenetrated.
Yeah, it's kind of not the greatest quality.
It's also interfered with the large fusion diaphragm.
Mm.
You know, on the right side, it looks a little blunted, maybe small pleural fusion, but the left side definitely is large.
Mhm. What would, all right, so if you're looking at this, you're totally correct. There's a large left and small right. What delineates large, medium, small, extra medium, petite? What all sizes of pleural effusions? Like what would delineate, like what makes you say this is large, that's small? Is there like a cutoff or anything? Yeah, no, it's like edema. It's like totally arbitrary, like depending on how big you think it is. So I would say something like that where it's just blunted, just small or trace. maybe something that's like, I don't know, to here is small, to here's moderate, here's large. I don't know. There's nothing really perfect. The biggest takeaway on this, how do you know that this is a pleural effusion and not a infiltrate?
No problem.
That's right. So no air bronchograms.
The meniscus, like the way the fluid.
Yes, absolutely. Basically, yeah, if it's a true lobar infiltrate like that other one, it'll be more squared off and flat. And then here it's kind of down sloping and you can kind of see the effusion there. Other big points about effusions, chest x-ray always lies. So this, I've seen literally chest x-rays that look like this right here. And then you go ultrasound them and we get like 800 cc's off of them with the Thora. And I've seen stuff that looks like this and we only take off 800 as well. Don't know why. So anytime there's someone who truly has respiratory distress and they have an effusion, you can ask consult procedure service, let us ultrasound them, drain the lung if we need to. The other thing that's super confusing about chest x-rays that we run into, specifically in the hospital, everyone we have is laying in a bed, they're not well, they get a portable chest x-ray. When you take portable chest x-ray, they're laying at 30 degrees versus the upright. This is probably an upright film. This is potentially a pleural effusion on the other side in a supine patient. So, what's up? Oh, what's up, dude? So yeah, so this is called a layering effusion. Essentially, if you're laying down flat like this, it's basically just the fluid is laying out flat in that lung. So there's no way to tell is this small, medium, or large. It's just a thin layer of fluid that's all behind the lung there. So again, feel free to consult procedure service. Questions on that?
I always had that line on the left lung. That's like, I don't know.
This,
Oh no, the left lung. Yeah.
Oh, right here?
Yeah.
so those are the scapulas. That right there,
Okay, okay.
it's going out that way, and then that one. No, it absolutely has fooled me, but yeah, I literally have thought I've seen like a pneumothorax before looking at that. So yeah, it's just tracing the. Wish I could see another one. That one, that's not really still kind of hard to see, but yeah, that's scapula. Okay, I think that's only pearls on effusions. Okay, we see this all the time. 55-year-old guy comes in wheezing. He looks like he smokes 37,000 pack years. Anyone? He probably does have COPD. How would you describe this chest x-ray? Okay, hyperinflated. What makes you think that, or what would make you say this is a hyperinflated?
It's below the cardiac.
Mhm.
Long.
Yep. Wait, what about the lung?
The lungs are long.
Long.
You've lost convexity in your,
Yes, that's another one. And then just the lung tissue itself. So people who are COPD, so tissue reflects in the chest x-ray is more white or transparent color, whatever you want to call it, less or more opaque, excuse me. Whereas lung tissue has more air in it. Air is just totally black on a chest x-ray. So these people are just hyperinflated. So black lung, kind of even on both sides, barrel chested, long. There's probably, you can even count rib, that's probably down to like rib 11 or so down here that it's expanded. And then almost a lot of times their diaphragms will be like a L shape. So it's like very flat or a flattened diaphragm compared to like our last guy, where you can kind of see it's like a very nice smooth hump there versus flat. So that's really all I have on COPD chest x-rays. Diaphragm's flat, there's extra air in there. All right, going forward, next case, 40-year-old comes in, admitted to surgery for diverticulitis, and then now they're on 1 or 2 liters oxygen requirement overnight. Anybody? Anybody in the chat want to take a guess?
We get called.
Oh. Anybody? MG?
So,
Sorry, I might have just given the answer away.
airways is midline. Nothing stands out.
Yeah.
From a bone standpoint, cardiac silhouette looks fine. On the diaphragm, it looks like there's intra-abdominal air on the, that you can see on the right side.
Yep.
And then the lungs look pretty clear.
Yep.
So I guess they just got, I mean, that would be a sign of a perf in this patient.
Absolutely. So you're spot on with everything. That's what it was. Biggest takeaway points. So if someone just has surgery, so when you have a laparoscopic or open abdominal surgery, mostly laparoscopic, they pump your belly full of air to basically inflate you to have room to operate. So if someone just had like a lap chole or they just had a peg placement, it's not technically abnormal to get a little bit of free air in the abdomen. So that's when it kind of comes to a clinical decision where it's like, is their abdomen exam worsening, or is this just a post-op? There's a little bit of air in there. There's nothing like a bowel perp or something that, you know, catastrophic happened. So just be aware of that, because I've seen that on a ton of post-peg x-rays. So questions, concerns?
How come you don't see it on the left side? Is it just mostly because you're working on the right?
Yeah, it's probably that. This is just whatever, one of the first Google images I pulled up. But yeah, a lot of times you actually will see unilaterally, especially if the patient were to be like laid on their like right side or left side, the air will move to the top portion. All right. We got, okay, so I didn't get gift cards, but I'll get you a Starbucks gift card in just a little bit. This is one question. That's gift card worthy. So 26-year-old female, fatigue, dry cough, dry eyes, maybe some on and off fevers for a month. What is going on with this chest x-ray and what's her diagnosis?
Technical quality is fair. Airways midline, see her trachea branching out. Bones, from marginal top to bottom. C, cardiac silhouette, not enlarged. D, diaphragm, normal, clear angles, maybe a touch flattened. E, everything else. So she's got what seems to be bulky hilar lymphadenopathy. You've got these bulky kind of little lumps sitting right next to the great veins.
Yep.
No clear infiltrate. You got lung margins all the way out to the periphery. So young, other like dry mucous membranes. I think about scleroderma lupus or something like that, or Sjogren's, or sarcoid.
There it is.
Yeah.
All right, that's gift card worthy. You were right on it. So yes, so typically in a chest x-ray, if someone exhales, this distance to this distance will get smaller and their vascular congestion will look more because all the, like as the lung tissue shrinks down, all the vessels come closer together. But this is like true bulky, big circular looking thing. So this is like the standard board question. Young, white female probably comes in with these symptoms, has this on a chest x-ray. Immediately first off, sarcoid.
Or fourth thought, if you're me.
I mean, you're all over the autoimmune. It's, I mean, all autoimmune diseases are kind of made up anyway. Fertile room. You just kind of, yeah, they'll figure them out. Okay. All right. This is for, hold me accountable to gift cards. I've got to get by there after this. So you get a gift card. So next up, this is all, there's a gift card question in this vignette. So 77-year-old female, super short of breath, comes in with this trash, as Rachel would call it. All right, who wants to take a guess at this one? Just tell me how you would describe it, and then kind of what your differential might be.
Airways deviated to the right a little bit. Bones are fine. Can't really see the cardiac silhouette because the whole left side's whited out.
Love it.
ABCD diaphragm, again, can't see the left. Right, looks maybe a little blunted to me from here. E, everything else. So my differential would be, have they been coughing? Is there a mucus plugged where they plugged off their whole left side? I don't think it's a pleural effusion that's that extreme, but that would also be up in there. I'd want to put an ultrasound on them to know.
Boom. All right. Well, you just nailed it. So that's literally the two differential is this lung totally atelectatic? Have the mucus plugged off this whole lung from a left main? Or is it fluid around the lung that's basically just filling up to here? So this is for the gift card. How do you know if this is a pleural effusion or if this is atelectatic? And you've already, nope, look at chest x-ray. Oh, ultrasound machine is broken.
Look at the chest x-ray now. I mean, I guess you can, to some extent, you can follow your like trachea down to where you deviate off, and if there's.
You got it. Yep, so you're right. So essentially, if you have extra fluid here, it's gonna push the trachea away. And now if it's atelectatic or mucus plugged, the lung is gonna shrink down. The rib spaces will get smaller and it will pull the trachea towards the side. That's literally the only way. If you don't have an ultrasound and you look at this, wide out, look at the trachea, it's away. This is probably a pleural effusion. Let me see if I have another example of that. Oh God, that's a horrible picture. I'm sorry. The only thing I wanted to point out on this one is this is going to be a wide out on the right lung, but this is atelectasis from a mucus plug. So it's kind of hard to see, but trachea is kind of deviated to the right side up here. And they have an intubated, so it's much more common in ICU that you see the mucus plug side of things. But if you look really closely, like right here and here, see how these ribs are only like a centimeter apart in this picture, whereas over here, it's probably twice as large. That's just because when you have atelectasis, the rib spaces will collapse a little bit. That's another way to tell. Questions on that? All good. All right, got two gift cards so far. All right. Here's a crappy chest x-ray, but a clinical scenario you may run into. 89-year-old Meemaw comes in not looking right. Family dropped her off, no history. They think she may have had like a cardiac syncopal event or something. The cards fellow is like, do they have a pacemaker or an ICD? Because I'm the cards fellow and I don't want to come interrogate it. And you're like, I don't know. I'll find out for you. How do you know from looking at the chest x-ray if this device is pacer or an ICD?
Have to do with the leads or the battery, or is it with cardiac positioning?
So it does have to do with part of the leads. So what you do is you look at the wire. So this is a dual chamber. So there's one lead here and one lead here. But now these wires are kind of thin and pretty translucent all the way down. So this means it's probably a pacemaker because an ICD has a shocking coil in it. So what that looks like is this big old bright thing right here. Now, sometimes that will be higher up here because it'll be installed on the first lead sometimes. So if it's anywhere from like the trachea down this way and you see a big blob, that is an ICD, no matter what the patient tells you. Meemaw's altered. You know what the chest x-ray shows. Boom. So that's just a little, don't worry about the chest x-ray otherwise, but that's.
An app that you can, like there's an app and you can just pull up the chest x-ray and the camera on your phone, put it over the pacer, and it'll give you like the model.
What?
It'll read like the internal makeup.
Yeah.
Yeah,
Just like
it's called
based off how like
pacemaker
the
ID.
model looks on the chest x-ray, it'll give you like St. Jude, X, Y, Z.
That's beautiful.
Pretty cool.
Okay. And as y'all all probably know, all ICDs can pace, but all pacemakers cannot shock. So, yep, just look for the big white blob there. The other clinical scenario is this Dopphoff or OG or NG tube placed correctly? And why? Yes or no? Somebody's-
I mean, I would say, yes, it's in the stomach, but it's not that far down.
Yep. That's right. So these are a little bit of like a judgment call, but there's two things. I think there's only one thing I think I might have found on the up to date. It was like actually gave a link. Do y'all know the link that past the diaphragm you may want to go to say like probably in there?
5?
Close 10 centimeters.
That was my second guess.
So, yeah, so 10 centimeters past the diaphragm. And then I guess this is the dop off, because a lot of the NG tubes have like a little second port here. And on this one, it might be hard to see, but essentially this one comes down, we're past the diaphragm, probably 10 centimeters. And there's like a little notch here in the little lining on the tube. You want that past the diaphragm. Once you get that in, that is far enough regardless of what this tip is doing. It may curl up in the stomach, it may go post pyloric. But as long as that's past, you're 10 centimeters past the diaphragm, you're good. Tell them to go forth and conquer.
On the one on the right,
Mhm.
would you tell them to advance?
Yep, I would probably tell them, push that in like another like 7 to 10 centimeters.
Yeah.
Because worst case scenario is just gonna kind of curl up in the stomach and it's somewhere you can use. And that's probably okay. I would just worry that like the patient moves his head and then it like retracts to up here and then it's a whole issue. Okay, similar question. Is the chest tube placed correctly? So don't even worry about interpreting all this other than is this thing in the right place when we're managing CV surgery patients for them? And it's a very similar finding as the last thing to know.
Yeah, I mean, I think it's fine, just if you see that port.
Yep.
It's still inside the chest.
That's perfect. So chest tubes, they can do the same thing. You put them in here. Looks a little traumatic, some
Yeah,
acute
really
air.
They got her.
So it's in and you want it to be in far enough, whether it goes up here, whether it goes this way, whether it kind of sits down here, that's fine. But you want to make sure that this port is past the kind of the wall of the pleural lining here. Otherwise, what'll happen is this will be out here and it'll start sucking air and you'll wind up not resolving this little apical pneumothorax up here. So that's how you tell us. I mean, I know we normally have other people help manage our chest tubes for us, but that's just a way to know like, oh crap, like the patient rolled over in bed and it kind of moved. Is it still working? Is it in the right spot? And you can tell just based off of that. Okay. All right. Final question. This is for the final gift card here. So 54-year-old guy has AML. He has a bone marrow transplant and he is getting all kinds of chemo. Onc is capped. He comes into us. He's septic, coughing up some blood. So the two questions to get the gift card are you can either get one of the parts of the question right and get a $5 gift card, or you get $10 gift card if you get both answers right. All right. Oh, we're really wheeling and dealing some money today, guys. Come on. Come on.
Make sure you have the chat in case.
Okay. We'll offer this to the chat people first since they've been silent. Okay. So one is, given this guy's history of being immunosuppressed, on chemo, coughing up blood, what is the diagnosis is one question. And then B, what is this finding called? You don't have to describe it, but you have to tell me what that is. It's a clinical thing. If you can get both those right, you get both the gift cards. Anybody from the chat? Offer it up?
Plasma.
Oh, what?
Just no plasma.
Oh, that's a good thought, actually.
Check on the chat, make sure that no one's typing in.
Yeah, cavitary lesion.
Cavitary lesion. Okay. It is a cavitary lesion with something in it. Not PTLD. Good thought. Anybody can guess.
I'll answer, but give away my gift card, right? But I'll describe it as a granuloma, and I'd be worried about either like fungal or like a mycobacterial one, since that's like getting a little off in there.
You were all over it.
So-
So close.
Alexander said TB,
So
something
close.
to think about.
Oh,
lobe,
not,
down
not TB. Those are great thoughts. Y'all are all around it.
Aspergillus,
Boom, aspergillus.
it's a fungal ball.
What is the fungal ball called?
Um, Axiating granuloma.
Oh, it's an aspergilloma.
Um,
Yeah, I mean, whatever, yeah. But y'all are totally right. This is so someone, I feel like I saw this a lot on onc wards as a resident. In people who have acutely got chemo, especially bone marrow transplant people, they're at a super high risk to have fungal pneumonias. So if you have onc patients, have a low threshold to check a T2. If they're ever coughing up blood or have a cavitary lesion, you're not wrong to empirically start them on micafungin and then kind of ask for, forgiveness later from ID if that's not what it was. But yep, that's an aspergilloma. So basically that's a fungus ball that has grown inside of a cavitary lesion, and then they have aspergillus. Okay. Questions, concerns, feedback? Got nothing.